One of the several factors that have sadly plagued the Nigerian healthcare system is the incessance of industrial action. The most recent one is the 7-day warning strike that has now been called by the National Association of Resident Doctors. This is particularly in a place like Nigeria's capital, Abuja, where the healthcare system has been described by these doctors in terms that are rather very pathetic. Again, this highlights how much of work needs to be done to turn things around within the healthcare system in Nigeria. Time and again, issues have been raised. We've had conversations around medical tourism and Nigerians across classes going abroad to seek medical care. But the question is, what exactly are the underlying factors driving this rather disturbing pattern in our healthcare sector? Lately, the phenomenon locally referred to as Japa has become a worrying trend. However, the question is, are we ready to put in the work, roll up our sleeves, and ensure that this becomes an issue of the past as quickly as possible? This morning, I'm joined by Dr. Tokbe he's the national president of the National Association of Resident Doctors. I should say Dr. Tokbe Osundara. It's a pleasure to have you on the program. First of all, short notice, we appreciate that.
It's a pleasure.
Great. Let's not talk about the strike, really. I mean, NARD has always gone on strike. There are people who believe that the motivation for these industrial actions is always largely about the welfare of doctors. I mean, talk to us about that.
All right. Thank you for having me. Motivation about strike is not about us, but rather about the patients. And if you observe, you notice that we are not just concerned about our own welfare. We have an holistic approach to things. And whatsoever is happening within the healthcare system is to ensure that we are able to deliver, best healthcare service to our patient. But the conveyor of this the service delivery, they are the doctors. So if you have a conveyor belt, if you get to airport and your bag, your luggage is supposed to be delivered to you, if your conveyor belt is faulty, that means you are not going to have your luggage. So if the conveyor belt now the doctors are representing the conveyor belt, and there is something that's systematic fault or fault of any kind, it's happening to it, then of course the service delivery will be hindered, or the service delivery will be suboptimal. So what we are saying is that if you want the best healthcare service delivery, quality health delivered to the people, we are campaigning for universal health coverage. As part of universal health coverage is to deliver quality health services that will meet up with global best practices. So if those things are not factored, of course, whatsoever you are doing is just shambolic, and we do not want to render shambolic, service delivery to the people. So essentially, it is for the best or for the good of the people, and that's the people of Nigeria.
Incidentally, I mean, your FCT chapter of the NARD has been very unequivocal about his terms, his choice of words regarding the state of healthcare in Abuja. Talk to us about that peculiarity. Why is the case of Abuja unique in terms of healthcare?
Well, it is the same thing that is affecting Abuja is also affecting some other states. It is affecting us at the federal level too, right. And it is because of the political unwillingness of some of the people who are saddled to take care of our healthcare system, and that starts with the governors, the minister. For instance, in Abuja here we have a minister of FCT in person of in some wiki. So it is because of their unwillingness to address issues that is affecting both healthcare, the total package of healthcare system in Abuja. And that has also cascaded, you've been seeing it in several other places. In Kaduna too, they have issues. In Osun State, they are presently on strike. Kaduna just resumed back to work, I think a day or two ago. So it is not peculiar to Abuja. It is becoming something that we are seeing, every time in the federal system. The same thing is happening. So there is no commitment to improving the healthcare workforce, to improving, the healthcare system in the country. Remember that there was a policy released by the Honorable Coordinating Minister of Health and Social Welfare, and that policy, it should not just be left at policy. There should be a driving force to implement the policy. That is when those policies will be effective. But what's the essence of you having a paperwork without implementing what is contained therein? So it's a little bit appalling, and we are not too happy with the trend of things. Of course, Abuja, this is not the first time Abuja will be going on strike. I mean, doctors in Abuja. So they've gone on strike over the same issue, and nothing seems to have been done to it.
One of the core issues, I mean, from what we understand in the media space regarding the problems in the healthcare sector is funding, especially the, if you like, insufficiency of it. To the best of your knowledge, I mean, you hold a very crucial leadership role in the healthcare system. How much do critical stakeholders in the healthcare sector contribute to the budgetary cycle of Nigeria as it has to do with health, for example?
When budget is to be made for the healthcare system, it is only done at the federal level between the presidency, the Senate, and the Ministry of Health. So nothing concerns resident doctors or even our parent body with the budgetary allocation for health. So
they are not brought into the conversation on any level at any time?
No. So whatsoever allocation that will be made for health will be done. There are several, departments within the Ministry of Health that handles budgets. They prepare it themselves and they send it to either the Senate or wherever it should go to. So it doesn't concern us. And maybe that is also part of the reasons why we are having issues, because if they had contacted us or consult us for maybe advice or something, we have proficient people who could give them reasonable solutions to some of the problem. And unfortunately, Nigeria seems to be at the forefront, but we are not leading appropriately. We hosted African Union sometimes ago in 2001, and we had Abuja Declaration. But we that hosted, they eventually agreed that 15% of budgetary allocation should be given to health. But what is Nigeria doing? At some point, we have 4%. We are struggling between 4 and 5% now of budgetary allocation for health. So the healthcare funding,
that's just for allocation, not the actual release at the end of the day.
Exactly. In fact, from what I've been told now, it even seems that the 2025 appropriation bill has not been effected. So there is a whole lot about funding for health that sometimes we begin to wonder what is even happening in our country. And if you don't pump money, healthcare financing is very important. It's a driving force. Nothing will move if the healthcare financing is not there.
Well, let's talk about leadership. I mean, I'm not going to put you in the spotlight for any wrong reason, but then we have to talk about these issues. I've spoken to your colleagues time and again. I mean, we had a brief conversation with the Honorable Minister of Health, and I mean, who doubles as the Coordinating Minister of Social Welfare, Dr. Ali Pate here, about 2 years ago. And one of the things he told me on live television was that the government is making efforts to ramp up, if you like, investments in terms of critical health services and things like that. And people said, well, this is a kind of turning point for the healthcare system in Nigeria. Let's talk about how effective or otherwise leadership has been in terms of driving Nigeria's healthcare sector.
Well, what I'm going to say is that for each minister that comes on board to lead the Ministry of Health, they come with their own templates, they come with their own ideas.
Right.
So sometimes what a previous minister has done is not the same template that an incumbent minister is going to follow. So that also in a way affects the shape of things within the healthcare system, because there is no pattern that we follow. Okay, if you have, a standard, everybody just keep to that standard and follows it. But everybody wants to impress, they want to, bring their own idea, which is not actually bad, as long as those ideas are implementable. They are not just white elephant projects. They are fine. But, the essence of leadership is to ensure that things work. The Honorable Coordinating Minister of Health is also trying, but as much as he's trying, the final, the final work is not left on his table. For instance, if he produces a policy and he sends that policy to the presidency, there is someone that will finance whatsoever is contained there. Right. So it will appear like the minister is working, or is doing everything he can to ensure that things go smoothly. But unfortunately, those who should support him to actualize some of the things contained in the policy, they are not doing their work. So the money is going to come from the finance ministry. The money is going to come, approval is going to come from the presidency. So if he's not getting the money from finance and he's not getting approval from the presidency, what is he going to do? So it's more or less like you just have a minister of health that is incapacitated because there is no approval, there is no money. So whatsoever is done, whether you have the best of policy, the best of ideas, if there is no political will to implement those things, or people are not saying what you are saying, of course, it just be there. Those policies are just going to be paperwork, and they will be stored somewhere. Another regime will come, they will bring his own idea, and it keeps going on in cycles that way.
We've heard ministers of health in this country. We've listened to some commissioners across the states, and they say you doctors are part of the problem. And their reason for that is very simple. They say you doctors make your own health, your private practice, I should say, more of a priority. In fact, priority number one, as against your service within your public sector commitment. And they say when you do that, it means that there's going to be a tilt, and that tilt is part of the fundamental issue that we're dealing with in the healthcare system in Nigeria.
I don't subscribe to that insinuation. If you go to, in fact, what we are doing, as residents and other doctors within the healthcare system,
including consultants.
I can't speak for consultants, unfortunately, because I'm not yet one.
Right.
But I can only speak for my own members. And in speaking for my own members, my members are not licensed to own hospitals. So you hardly will find any of my members who, Nardites, we call them Nardites because they belong to the Nigerian Association of Resident Doctors. So they don't own hospitals.
But don't they provide services to private facilities?
Of course, you can provide service to a private facility as long as it is not clashing with your own primary assignment. For instance, you don't have jurisdiction over what I do with my time after I'm done with the day's work.
Your primary assignment.
Yes. So if I have a contract with government that I'm going to work between the hours of 8 to 4, and I'm done with that, so I've fulfilled that obligation. Whatsoever happens with my time after 4 o'clock is none of your business. So if I go to a private hospital to work after 4 o'clock and I don't have any contract or agreement with anybody, so whatever I'm doing there, as long as it is ethical, I really don't think anybody should raise an eyebrow. However, I want to address the initial question you raised. In fact, if we do not have the number of private facilities we have in this country, there will be a problem. The reason is that the hospitals that we have presently, it is not even adequate to take care of the number of people that are coming to the hospitals. Sometimes you get to the hospital, you have myriads of patients waiting. They waste their time. Sometimes they are unable to see a doctor. It is just only one consultant in a clinic, and he has maybe about 20 patients to see. Who are new patients?
In one day.
In one day. So by the time he's done, he's even tired, mentally fatigued, physically fatigued. And that is why some of them opt for a private facility where a doctor will be readily available to see them. Of course, they will pay for the service. So remove all the private hospitals in Nigeria and see what will happen. You just see chaos. So we should find a balance. As much as, of course, I really have not seen any doctor that is working with the federal government or with the state government that will now prioritize either a private sector, if he has a private facility, over what the primary job should be. You can have a private facility, but a doctor will always be there. So it is not like you are working there, then you junket from here to another place. No, you can't do two things together at the same time. So most of the time, you know, for those who have private facility, they have, you know, doctors who are permanently working in those facilities to take care of patients that or clients that come visiting. So you know, I don't want people to begin to have this notion that we prioritize private facility, or we send patients from you know, the federal government hospital or state government hospital to a private you know, facility. Definitely, it's you know, we could have reasons for that. For instance, if MRI is not available in my own facility, and MRI is not in town, and a private facility has MRI, what am I supposed to do? I'm going to send the patient to the best place where he can
where services are available.
Exactly. Those services are rendered there. In my state, there is a private facility that has MRI, whereas I work in a facility that doesn't have MRI.
A public facility?
Yes, a public facility. What am I supposed to do? To tell the patient to go to Lagos? No. I'm going to tell the patient, see, there is a private facility here that has this service, and they are willing to render the service to you. Patronize them. So somebody will now come and be telling me that I'm prioritizing, you know, a private care over what the public care should do. No. If the services are available, they will patronize those public enterprise or public hospitals. And, you know, things go smoothly. So there is a synergy that comes with, you know, between the public health facility and the private health facility, because services, you have Medicare. Medicare is in this country, Union Diagnostic, Africa Global, and all. I'm not advertising for
quite a number of them.
Quite a number of
private entities.
Private entities. Just because most of our public facilities are not able, or they don't have the capacity to render those services to people. And that is why they came up, and you cannot tell them to go back until we are able to have our own public facility that will be able to render all the services that is needed.
I mean, brilliant points you're making here, Doc. So here's the thing. You and I can agree on one thing. Nigeria's healthcare system is in a bad place. End of story. However, your last response has made my second question easier. Right. Do you think, I mean, from what you know, what you're seeing, and what your instincts tell you, all of the things playing out in front of you within the Nigerian healthcare system, that there could be an agenda to leave the system broken as it is today for whatever reason? Because it looks like there's a plot, it looks like there's a bigger scheme going on somewhere, because this isn't making any sense anymore, is it?
No, I don't think so. I think otherwise is the case. You know, we don't call our political office holder to question in this country. The first thing is that.
So you think this is a case of negligence?
Yes. I mentioned that a whole coordinating minister released the policy. What has been done to that policy? How effective has been the policy? Now, there was a time, UCH, University College Hospital in Ibadan. You know, people went on strike because there was no light. What has been done? Of course, there is a program going on to improve on the electrification of some of our hospitals. Right. In fact, they are going to start the program today.
Especially the federal ones.
Yes. But if you go to some of these hospitals where there is no light in the theater, you have to use a torchlight. Are you going to blame, you know, the hospital management or a private facility that is rendering the service that a public facility could not render? But we have to hold the political office holder responsible. Why are you not providing electricity? Why are you not providing the equipment, the needed equipment? How many facilities in our country have MRI? How many of them have CT? Those people who have MRI, they could not even maintain the MRI because the MRI will be on constant power supply. So, and these days, this is expensive, petrol is expensive. So to sustain, you know, healthcare and the equipment is actually challenging for the hospital management in, you know, most of our public facility. So I think that if we are going to address the issues bedeviling our healthcare system, it starts with those who have been saddled to take on responsibility on our behalf, to call them to question, why is this not happening? We have an agreement that 15% of budgetary allocation should be given to health. Why are we having 5%? Why are we having 6%? And that 5% is it properly channeled? So these are questions that call for answer. But who is going to provide the answer? It's another issue.
All right. I think that we have a couple of more things to find answers to this morning in the course of the program. We're taking a quick break, everyone. When we return, we'll talk about how effective or otherwise these strike actions are. But all of that and more after this break. Please don't go away. So let me take you back to the issue of strike. That's what we got off from a while ago. I've spoken to labor leaders time and again, whether it's NASU or, all of those, unions, when they talk about strikes and the things that government is not doing for them, about the different institutions and all of that. And they say strike is always the last resort. So the question is, first of all, this is a warning strike. What happens when this 7-day period cycles out? Probably your association goes into a full throttle strike. Again, what happens if that doesn't yield the desired or expected results?
I do believe that we have a government that has an human face. I do believe that our voice has not reached the presidency well enough. And this platform that you've created is another medium to herald what we have been saying or the concern. So I believe that by the time it gets to the presidency, they will find something to do. Especially the Honorable Minister for Finance too. They will do something within the shortest possible time. So I don't want to think that after a warning strike, they will leave us and leave whatsoever we're agitating for and allow, because it is not about us this time around, it is about the people. So if the whole hospital in Nigeria shuts down, the Nigerian Association of, the members of Nigerian Association of Resident Doctors form the largest bulk of doctors working in the country. We are the youth wing of doctors in this country. So just imagine that the youth wing collapses, the hospitals are not working effectively, the consultants are there, but how much will a consultant do when other people who are supposed to support his work? In fact, most time they will not be able to go to the theater to operate. They can't run the clinic all by themselves. So invariably the hospital will be shut down. So if the hospital shuts down, for how long does the government want this hospital to be shut down? For how long do we want to keep our people perpetually in pain? Because when there is a problem with the health, of course, it will come with pain. It will come with several other symptoms. So how long do you want them to suffer under those symptoms that come with the illnesses that they have? So I think that government has human face, the Ministry of Health has human face, and I do not believe that they will just, in fact, ideally, they shouldn't even allow this strike to happen. That is, for government that are very responsive and government who have a responsibility towards the people. And I do believe that this government has a responsibility towards the people. So irrespective of the duration of the strike, I'm believing that something will be done, to avert it in the first place. It shouldn't even happen. Then secondly, if it happens, I believe that they will call us and we'll be able to profile a solution going forward.
We're seeing, very unfortunately so, an aggressive exodus of doctors and other healthcare professionals leave this country to other parts of the world to practice and things like that. We've also seen, in our lifetime, where a former minister of health in this country said that there's no rule that stipulates you must practice as a doctor after med school. That you can go to agriculture and go to whatever other fields you want to go to. Help us make sense of that in light of the reality we're dealing with today. And then second, the specifics we can do as a government to be able to see how we can reverse this so-called Japa trend.
All right. It's unfortunate, the reference you made about a minister who said doctors are even sufficient and we can begin to export them out of the country. Unfortunately, the reverse is the case. The WHO standard is a doctor to 600 patients.
Right.
But what we have is a doctor to approximately 10,000 patients in our country. If I'm to see 10,000 patients, of course, several other things will come with it.
You will now need a doctor yourself.
Yes, I will need a doctor myself. So physician is needing a physician.
Right.
So these are part of the problem we have and part of the causes of this Japa syndrome. Another cause is that, medicine is very demanding. Medicine on its own. The society is even expecting so much from you.
Right.
That is weighing so much on mental acumen, emotional ability, that there is so much that is expected. A doctor is saying like a God, and perfection is expected from you. So everything you are doing, you are driving towards perfection. I must not make a mistake. I don't want my work, to be blemished. Those things, coupled with the fact that you now have excess workload in terms of the numbers of patients you are seeing, your commitment to work, what you need to learn, what you need to unlearn, how to meet up with the best global best practices. All of these things are affecting us psychologically. They are affecting us mentally, physically. Sometimes the remuneration incentives that should come even to make you a little bit satisfied with what you are doing, they are not coming there. A doctor doesn't have any business going into agriculture. Right. Of course, agriculture is allowed because that's what can keep every life, soul and body together. But the doctor doesn't need diversifying into other things. You should just concentrate on your job. When the remunerations are right, the incentives are right. If you go abroad, you hardly find a doctor diversify, except you are not practicing. You are a doctor. You can study medicine and surgery, but you felt that you are not going to practice, then you diversify into something else. That's fine. But if you are really committed to this work of medicine, you really do not have sufficient time to go into other things. Right. But if the incentives are not right, definitely, of course, people will find levels and they would want to keep body and soul together. So, like you mentioned, part of the reasons why you have Japa syndrome is because the jobs are no longer satisfactory, incentives are not right, there is serious burnout, among us. And one thing the government can do is to first look at how to safeguard doctors from working excessively. Right. Nobody pays for the overtime you are doing. The excess workload, nobody pays for it. But the doctors are still doing it. The other thing they need to do, the thematic area and that policy, incentives. When the incentives are not right, incentives are supposed to be adequate, they are supposed to be competitive, they are supposed to be attractive. But if the incentives are not adequate and attractive, of course, people will find, countries or places where they have if you work with global television, and another TV station is calling you and they're saying they are going to pay you maybe 2-3 million naira per month. I don't know how much they're paying you. Of course, your first instinct will tell you that, what am I doing here? Let me go elsewhere. Except there is something this TV station is giving to you that you can say, oh, I think I have some leverage, I have some satisfaction. If that is not happening, of course, the next thing is that you are going to move out. So the same thing applies. Those are the pull and push factor that drives people out of this country.
In other words, we need to stop living in denial and face the reality. There's a last question I want to ask you, Doc, just before we let you off this morning. There has been the conversation very recently when these strikes became incessant amongst healthcare professionals to say that, look, the cost of training a doctor in Nigeria is almost free when you compare to an average country elsewhere in the world. And as such, these doctors should at least be patriotic, should love their country enough to not want to be towing this path of strike or having to leave the country at every turn. I mean, is that not a fair argument to have, to say, okay, cut the government, cut the people some slack, giving the fact that your training is next to free, according to those who follow the industry closely. I mean, the sector.
All right, that's not being fair on the doctors. So you want the doctors to be in perpetual penury and poverty. We pay higher school fee than any other person in this country. Our textbooks are more expensive. The demands of medicine and surgery is even more. Now, compare medicine and surgery with law. We do more work. Of course, I'm not trying to belittle what the lawyers, they are fantastic, astute people in our society. But as much as we want to compare, let us be fair. Go and look at the salaries of the judiciary. A magistrate in court is not even up to a consultant in the hospital. How much is a magistrate collecting? How much is our consultant collecting? So if you compare it, you just see that there is, this biased way, jaundiced way of looking at things. Then secondly, people are not looking at, things holistically. The same set of, look at some of our private facilities that train doctors. How much are they paying? Even some of the state governments, they are paying so much. And by the time you are out of the medical school, it is not the government that is paying any of your, your fee to further your education. So there is so much that even the government cannot even do for the doctors. Of course, we appreciate what they are doing, but that does not mean that they should now, because you want the doctors to be patriotic, you now subject them to poverty. If you do, no problem. People will continue to migrate out of the country. There will be exodus. So if that is not the case, even the minister himself will not put as part of his thematic area issues of incentive. Right. Now, if you compare a doctor, we've compared a doctor to that of what's it called? Law. So the doctors and nurses and pharmacists, is it the same thing that applicable? Because the nurses are also living. Migration is a global thing. People will leave. So the only thing you can do to keep them is to improve on the wages, to improve on the condition of the working condition within the hospital. Whether you are a doctor, you are a nurse, you are a banker, bankers are also living. I know quite a number of bankers who have left the shore of this country because they are not satisfied with the banking work. So it is not, it is not about doctors. If better people, if people are giving me better incentives, Saudi Arabia, Australia, UK, US, Canada, if they are providing something that will better my life, I'm going to migrate if the country is not even willing to do as much as they are doing. So what we are saying is that we are not saying that the government of Nigeria should meet up with what US is doing. Of course, we are developing. Right. And I want to believe that as part of our development, there are levels to it. So, but do something more, more attractive, more reasonable than what you are presently giving to healthcare workers. Migration is not a doctor thing alone. It is affecting workers, nurses. It is affecting scientists. It is affecting pharmacists. So, to now, extract doctors alone out of the pool, to be injustice to us. So, look at why other people are leaving.
Right.
So I think with that, we will be able to have a better perspective.
All right. I would like to appreciate you for your valuable insights on the discussion this morning. I've been talking to Dr. Tokbe Osundara. He's the national president of the National Association of Resident Doctors. He's been helping us to find sense in all of the issues around the 7-day warning strike that the association has now issued. This is day 2 into the strike, I suppose. This is the second day.
No. We've not started.
You've not started. Okay, just give me.
We have a 10-day ultimatum that will.
Has it circled out now? How much longer do we have until?
By Wednesday evening, the 10-day ultimatum will.
Which is tomorrow evening?
Yes, tomorrow evening.
Has the government made any effort in terms of reaching out? I just wanted to put that on record.
The government has not made any, official. They've not given us any official invites to discuss. We've not had anything from them officially. But we cannot fold our hands because we don't want disruption in healthcare services. So what we do is to lobby, go behind the door to speak with this, speak with that, and sometimes they can deny you, just like what happened between Minister of Education and ASU. Whatever was done behind the scene, it was denied openly.
Right. So the 2009 agreement.
Yes. So we want, an official communication let us see what they want to offer. Let us come to table and discuss. But that is not happening now. And as it stands, my fears are my members may, because the government is not profiling anything, decide to go on this strike after Wednesday.
Oh, well, that's very thought-provoking at the same time as sad. All right, I've been talking to the president of the National Association of Resident Doctors, Dr. Osundara, and that's what we're leaving the conversation. We'll continue to monitor these developments even beyond the Federal Capital Territory so we can keep you updated on these developments. We'll take a quick break. When we return, Priscilla will be talking to a cybersecurity expert on what we can do tech-wise to be able to drive the efforts to mitigate security threats across the web. Do stay with us.